All right, everybody, welcome back. I'm Dr. Adam Rinde, and welcome to the next episode of the One Thing podcast. We're diving into the cellular trenches today, bypassing the usual surface level health advice for something much deeper. You know how we talk about optimizing lots of things on this podcast, such as sleep, diet, and exercise, but sometimes, even with perfect habits and all of those approaches, the immune system and the body still feels off. That's because there is a hidden battlefield at the microscopic level, one that governs how your body responds to any threat, whether it's a chronic infection, a toxic exposure, or even lingering emotional stress. This is called the cell danger response. And Dr. Navio, who came up with the cell danger response theory, gave us a framework of understanding these responses at a deep cellular level. And understanding the cell danger response is key to the future of unlocking true sustained health and well-being when approaching chronic illness. Think of it like this: we're all striving for high performance in our bodies, right? But the engine itself may be fundamentally misfiring, stuck in a protective yet damaging loop. Today, thankfully, I have a great colleague to reach out to help understand cell danger response theory. This is Dr. Paul Anderson, who's been on the podcast before. He helped us in this podcast navigate the complex terrain. We unpack the mechanics of the cell danger response, identify the factors that throw it off balance, and most importantly, equip you with a few strategies to help reclaim your health and begin the path of moving beyond chronic illness. So buckle up, everybody, because we're about to go deep. Let's get started, and welcome to the next episode of the One Thing podcast. Dr. Anderson, welcome back to the One Thing podcast. It's great to be here with you again.
Thanks for having me.
You're welcome. I really enjoyed our last conversation, and I feel so grateful that you were willing to come back on and speak with me about a topic that I think you've been in your career really, the things that you do really help us understand this topic more and more. So I couldn't think of a better person to bring cell danger response to our audience. So I'm excited to dig in. Yeah, just as a starting point, in your kind of experience, when when did you start seeing this philosophy really come into the forefront, the cell danger response, and if you could explain to us like what it basically is?
Yeah, I think this is an excellent example of if you practice long enough, you experience things and you see things with patients, and you're always looking for an explanation of why those patterns exist. And so for me, it was sort of in that order. Was I was always trying to figure out why maybe the chronically ill members of my patient group, reacted the way they did or had chronic illness, etc. Um, I don't remember exactly how long ago I first, heard about cell danger response, but some colleagues in another state had brought it to my attention as more of a defined science, I guess. We were talking about the component parts of it and chronic illness because that's their focus, and they had said, well, have you heard of Dr. Navio's work and cell danger response and all this? And that was the first time I'd put those words and that person together.
Mm.
And then talked, with people who, were really working with it. Then started reading about it. And I think the punchline really was, I started to see, oh, this is sort of the intersection of modern cell biology or cell pathology and what I've been watching people go through for a long time. And it's, there's different layers of, you can you can look at sort of the mechanisms of how people heal and how people don't heal. This is sort of a couple of layers below, looking at, mechanistically, why does the body, which is supposed to be able to heal itself, not always go in that direction, essentially.
Yeah. So maybe we could start by talking about what the cell danger response is by definition, and when it's functioning in a optimal manner, what it would do in a basic scenario of a threat to the human body.
Yeah. I think, the most basic direct path to kind of getting the big picture is we are set up with self repair mechanisms, within reason. And the cell danger response is a way of explaining when we have a triggering incident, which could be any number of things. It could be an inflammatory, infectious pathology. It could be toxic exposure. It could be trauma. It could be uh, uh, mental emotional stressors. It could be just pick anything that bothers the human body. Um, and the idea is that we have healthy cells, we have a trigger, and then we have a pathological response. Now, that's sort of usually specific to whatever the trigger was. So, if it's infectious, it's going to be more of an immune inflammatory thing. If it's toxic, it may be actually an autoimmune inflammatory problem or something. But then, in the simplest form, where we return back to health eventually, we develop, an acute illness response, injury response, something that's contained so that our body can actually get past it and heal. And one of the things that cell danger response added, I think, to the discussion and plugged it in was a moderately new concept in cell biology of extracellular ATP, and how when we have these, triggers and injury response, that rises. And so one of the triggers then to the cells uh, to repair inside is to trigger them to go into mitochondrial biogenesis, which means basically all of the energy apparatus of the cell needs maintenance. And if we have these triggers and insults and we don't maintain the all of the cell really, but the mitochondrial substance, which can be quite large and dense, um, we're not going to have normally functioning cells for very long. So it's a way to both kind of clean up old problems and get rid of them, but also make the cells go back to a stronger, healthier attitude. And so if you just take the acute model, then you come out, there's a few phases of getting the mitochondria tuned back up. And then on the other end of that, you actually wind up with lower amounts of this external ATP because there's less trauma in the body of any kind. And then the sort of newly tuned up mitochondrial apparatus in your cells can take you back to, healthy function till something else happens.
Hmm.
Uh, and so, yeah, chronic illness is just when we don't quite make that whole loop.
So, okay, so along the lines of the kind of normal functioning response, that's kind of like a healthy cell danger response. Navio talks about this concept of salutogenesis or salugens, and what how does that fit in, and what is that term? Just for people who aren't familiar with it.
Yeah, it's a interesting. The first time I heard it, I thought, is that a like because in cell biology, there's all these interesting acronyms and all this, and I thought, well, is that a cell biology acronym? And it's actually a process that's named after the Roman goddess of health, safety, and prosperity.
Okay.
So Salus, right? So salutogenesis is looking at really return to health, essentially. So if we look at it again in the maybe the way it's supposed to work in a acute healing model, when we get to that place where we have this buildup of extracellular ATP material and it triggers the cell danger response to repair the cells, especially the mitochondria, you could categorize all of those parts of cell danger response as salutogenic activity or salutogenesis. And basically, it's what does it take to heal? So to undo the damage that was done and repair and respond to the sick mitochondria and then come out the other side with a healthier cell. So salutogenesis is that, the three or four parts of the cell danger response working to repair the cell, essentially. So salutogenic, factors or salugens are anything that would help in the process of the cell repair, especially the mitochondrial repair.
Yeah, and it's interesting. So much emphasis in naturopathic training, or even just now, even I think beyond that, functional medicine, and certainly all over social media is like lifestyle factors, that help the body stay well. And I think of those as being salugens, like, the water you drink, the food you eat, the sleep. Is that fair
Mhm.
to say?
Yeah, I think, if we look at, if you demedicalize a body trying to heal and take it, maybe extract it from modern times, uh, the body is going to take advantage of anything, that is a so-called determinant of health. So that could include all of the things, including what we eat and fuel our body with, and what we drink and hydrate with, and moving our body through exercise and movement, and then sleeping and mental status, all those things, very, very important. And then, the other side of the ledger, which is much more of a problem now than it was even 100 years ago, is avoiding things that, are going to be sort of anti-salugens.
Right.
So you could think of toxic materials and things that are added maybe to our food or our air that if we could avoid them, we'd have less stressors on the body. All of those things. And you could certainly in modern times extrapolate that over to, if sleep is helpful and my sleep wake cycle is very important to my health, then things that disrupt it would be not a salugen, they'd be anti-salutogenic. So that could be maybe being exposed to a screen late at night and throwing off my sleep wake cycle, or um, you know, uh, because mental emotional stress is such a huge trigger of the cell danger response. What is on your screen? Most of the material, if you open up your phone or your TV or your computer and you go into any social media platform, the amount of it that's disturbing to you is probably a very high amount. So not only are you getting maybe the light disruption of your sleep wake cycle, you're also getting a mental disruption, of your stress response.
Yeah.
And so, yeah, I think, before you even get to any nutritional or medical intervention or anything, if those things aren't there, it's really hard for the interventions to kind of stick, I
Sure.
guess.
Sure.
Yeah.
Yeah, and I mean, this is kind of a little bit tangential, but we can come back to this. But I mean, when you're in a cell danger response cycle that's stuck, I mean, it's harder and harder to maintain those lifestyle
Yeah.
choices and habits, and because you're just not feeling well. So, with all empathy to what people are going through, the difficulty to uh, add salugens, the sicker you are, is just more challenging. So,
Yeah. Yeah.
so
That's definitely, it's part of the sick body sort of crying out for help and comfort at the same time.
yeah,
It's we'll often, dealing with somebody who's chronically ill, obviously all of these good things are very important, but you also have to kind of start where you are, the person is. And you also have to have some grace for the fact that maybe you've been in bed for, X amount of time, or the time you're out of bed, you're in pain all the time, or whatever. And you can't go from that to, having this sort of monk-like, magical
Exactly.
existence.
Exactly.
So yeah, it's like, baby steps
Right.
to get there.
Yeah. So just to set up the kind of the other end of this where the dysfunction starts, what what types of conditions do you think of um, really connect with cell danger response, dysfunction, or kind of a disruption in that cycle?
Yeah, I think, I mean, if you got more granular than, any chronic illness, I think some of the more common things that people, will have either direct or fairly close indirect experience with would be chronically fatiguing situations like chronic fatigue syndrome or fibromyalgia, people with chronic recurrent infections that don't seem to want to go away and they ought to. So the kind of the chronic infectious world of problems. One that we wouldn't have talked about 5 years ago, but is ubiquitous would be post-acute COVID syndrome, long COVID. It's essentially a very similar disorder to a multifactorial chronic fatigue syndrome picture, and it has a lot of the same triggers. And then if you dissect these long-term illnesses and you get down to, well, what would be causing them, and you start looking, it's it matches up pretty well with the list of triggers of the cell danger response. And one of the frustrating things I think in acute care medicine, standard medicine, is it's kind of set up for, I have problem A and I find problem A and I give
Right.
treatment A and we got a good match there. In any of these chronic sort of problems, you might not have this big giant problem A, but you might have 10 medium size, problem A, B, C, D, E, F,
Mhm.
G. And no one of them is pushing you over the edge, but they're all pushing on you. And I think that, this is why I say the first time I heard about it, I thought, well, this really matches like what we see in our chronically ill folks, because until we go looking for, oh, your fatigue and pain is really coming from, these three or four things, and your neighbor with the same symptom, it's coming from totally different things over here,
Yeah.
or some collage. So I think that, something I really appreciate about cell danger response theory is the triggers are pretty inclusive, really.
Mhm.
They include like a lot of modern modern humans issues, really, that we
Yeah.
can tackle.
It's interesting also just to build on those conditions that Navio has pointed out. PTSD, also
Mhm.
autism.
Mhm.
Some of his treatments have been directed towards um, autism spectrum disorder, and just to kind of think of this model of those conditions experiencing um, cell danger, uh,
Mhm.
is also expansive and just general like the aging process over time.
Mhm. Yeah.
So I guess with in scenarios where what kind of taking one of these conditions such as um, uh, chronic fatigue syndrome, fibromyalgia, you know, when through this lens, how would you see like this process taking place? So, for example, like, he talks about these different checkpoints or stages of cell danger response, and so kind of back to the beginning. And I know that there's lots of factors, but just basically, like, how does the process of the cell danger response go awry? Um, After, like, where does it get stuck?
Yeah. Well, I think that, so we should probably say the general phases that are gone through. So if you consider you're starting with a trigger and an insult of some type, the The first phase they label as the inflammatory phase. And, we always think in inflammation, we're always told, at least by ads for drugs, that we don't need inflammation and all that. There's lots of things to stop inflammation, which is good. It gets us out of pain. But actually, if we don't have inflammation, we never have an immune response. We never have a cell cleanup response. There's a reason we have these. The problem is if it doesn't go away, of course. So a normal cell repair, cell danger response would start with inflammatory chemicals that the body normally uses to signal cells to say either we have to clean these cells up or we have to go through a repair process, like in this case, mitochondrial biogenesis, and clean up the mitochondria, make new ones, etc. So the inflammatory part is just the initiation event. And so that's actually a good thing. And just for people to consider, at any of these steps, you can imagine, just think of the language of what the process is, you can stall, you can not move to the next step. And then you have, pathological inflammation. It just kind of keeps going, right? So, reasons for that, and this could be applied to any of the steps, but I think it's important for people to understand, and this is if you have a chronic illness, you will know this from your personal experience. You're not healing on the same schedule as and like somebody who doesn't have a chronic illness. So what is going on there? Well, the normal way, like someone with no chronic illness factors or very few does, they go through all three steps and kind of eventually get back to more healthy cells, healed, right? In a chronic illness situation, sometimes the triggers never stop. So if I never stop triggering, I'm always going to be feeding, phase one inflammatory repair. And at a certain point, your cells can't keep up with it. Like you're not made to have an inflammatory response that lasts long term. If we get a cold or get some infection, we have this big inflammatory upswing, but it's an upswing that has a downswing. It turns everything on. Immune system comes in, does its job, then it goes down. Um, in If I never stop triggering that, it goes up and it might stay up a long time. This is very well mapped out in both, you know, COVID cases that would progress, but also in long COVID, where the immune system is continually triggered in different ways, so it can't go back to normal. So that's kind of a classic example of the cell danger response going wrong. So the first thing is, this is why I think, in our profession, we're always long term looking at what can we do to take away impediments to cure. So if there's a chronic toxic exposure in your world, is there some way we can get that diminished?
Mm-hmm.
If there's an immunological and immune dysfunction, can we do something to calm that down and get it back to functional? If there's, you have no normal sleep wake cycle, your stress response is way off, all that, can we get those eventually, back, kind of get the genie back in the bottle there? But let's say we don't have something going terribly off the rails. We have inflammation, which just means let's turn on the healing processes. Then we have proliferation, which is I've triggered you to go through, make new mitochondria, etc. And then differentiation is usually the third step. Um, and normally what that means then is if I have proliferative activity, then I've built enough mitochondria to keep the cell happy and healthy. Differentiation is just sort of, think of it like settling all that cell change in. So I have a healthier cell. Go out the other side, the external ATP signaling goes down. We can go back to a healthier body with stronger cells, right? But you could imagine, certainly the inflammatory part could go off the rails if we keep stimulating it. Um, And the other thing, that clinically can be a problem is if this is a fairly early issue, you might have other problems that need to be treated. Might be nutrient deficiencies or a hormonal imbalance or, you know, any number of things. If you've been chronically ill and you may have those same problems because we're trying to take the triggers away, but those might actually aggravate your system because you're a little too weak for it, from a response point of view. So I think, where it goes off the rails has a lot to do with the level of how much trigger is still in the system or, coming in, but also how long have we not gone through the cycle back to the healing point, but, kind of dead ended.
Yeah. So I guess reflecting that back, kind of what I hear is, perhaps there are some people more susceptible for a number of reasons, probably genetically and environmentally, to get stuck in this stage where you were saying earlier the extracellular ATP is overwhelming the system, and the systems to resolve that inflammation are overwhelmed. And then, you know,
Hmm.
if the triggers are still around, um, then this cycle just kind of perpetuates. Is that fair to say?
Yeah. Yeah.
Um, okay. So, I think one of the things I grapple with this cell danger response is I want to be able to measure it so I can manage it. um, and I've struggled with figuring out how to do that. And I mean, I know there's some potential biomarkers that are brought up or what have you. Do you find that there's a way to clinically follow this, like through lab work or in any way that's been useful?
Yeah. Well, to us, the most positive statement I can make about that is I think we're closer than we've been for a long time. And as you sort of alluded to, there's there are ways to assess mitochondrial function. There are better ways now to assess genomic mitochondrial disintegration and defects and things like that. And I've looked at a lot of those sort of assessments and testing and things like that. Um, I and I kn- the people who in the labs who have developed these would disagree with this statement. But from a clinical point of view, I feel like on one hand, if somebody doesn't mind experimenting and money is not too big of an object, there are a bunch of tests you can do that might be indicative. Um, I don't know that we're at a place where we have a really streamlined, reliable, set of markers that would say, oh, things are calming down here, or or they're not, and the cells are leaky, and there's all this stuff happening. Um, and I think some of that is a bit of an artifact of, like I said in the beginning, I've done this a long time, and when you've done it because there were no tools, really specific clinical tools, you had to do everything by clinical response. And, certainly we can test for some of the triggering things. That's a little different. But to actually say, are the mitochondria just chronically inflamed? And then, um, maybe you can, maybe you can't. 10 years ago, definitely not. Now I think we have emerging tools, and I hope in 5 years, 10 years, maybe we'll have some really good stuff. But I personally don't have anything that I would use on everybody and say this for sure will tell me, oh, you're stuck here,
Mm.
So I think, and that's not to say that there's not an answer in the lab world. It's to say we're not there yet. I don't think.
Yeah, I appreciate that. I mean, I think there's probably, people out there that are running certain tests to figure out, the stuff,
Sure.
organic acids or
Yeah.
mitochondrial function tests, but it's really helpful. I think, when you know based on patients' response or their symptomology or shifts in their clinical presentation or how they're presenting as it connects to this scenario, I think, that's
Yeah.
that's kind of how,
Yeah.
medicine has always been practiced. But
It, it's and it would be great if there was like these 10 markers and we could follow them and you
but
know
we certainly
uh,
have markers to pick up on drivers and
right.
kind of what's pushing the system.
I think on the triggering side we're much better, like that's and so to a degree what I'll try and focus on with patients is we know that if the funnel is really full up here of things that are not helping your body, let's at least identify those, and decrease the triggers. The result will be that the danger response will move through as it should and not get stuck and dysfunctional. It's the it's the it's the mechanical part that I don't think we're really there yet, and I'm not against doing some of those tests with people and that sort of thing. Like I do use organic acids and some other tests that you get at your regular lab and all that. But what I tell people is these are not 100% predictive. So the only things we really learn from these tests, which can be important, is you definitely don't have this going on, this set of chemistry, biology, or if something's positive and it's reproducibly positive as we go through your treatment, and hopefully it gets better, then for you, that is truly a marker that we can follow as we go along. And, so then that comes into, because a lot of these things wind up not being, certainly not covered by their insurance and all this. And if they want more data, we can put together some testing and say, let's see if anything pops up. If it does, we'll follow those things. If it doesn't really mean you're not don't have a problem. It just means those aren't your problems. But I think we brought it up a little earlier, but I would 100% guess anybody with chronic illnesses probably had this happen or close to it. One of the clinical feedback things that I know I didn't notice earlier on, but then I realized what a big deal was, is you maybe look at the triggering end of, the business, which could be, we mentioned earlier, maybe infections or maybe toxicities or maybe hormonal imbalances, stress hormones or other hormones. You find things wrong there and then you treat it. This is human nature. It's also how medicine is usually practiced. I find these bad guys, I treat them, and then the patient is way sicker, right? And they're like, what, I saw the labs too. I understand we were supposed to do this. Why do I feel worse now? And that became like, the more became in tune to it, it was like, that's a sign. And when I first saw cell danger responses, this explains it better than anything I've ever explained with, is I am essentially trying you could use an engine analogy. You have a car, and it has a really dysfunctional bad engine, and you're trying to make it go faster by pushing on the gas. All you're going to get is faster dysfunction.
Hmm.
And so, I'll just give like probably the top few here that I bet people have had happen. Your labs say that your thyroid is low. You have some hypothyroidism. You take thyroid and you feel even worse than before you started. That is not normal, but that happens when you press on the gas and the engine is broken. You find an infection that's chronic and you go and treat it aggressively, like Epstein-Barr or something, and you feel really, really bad as soon as you start treating. Like you started not feeling great, and now you feel acutely bad. And it's like, well, that was the problem. Why do I feel bad from addressing the problem? And it's not so much that the thyroid was a bad idea or to treat that, or you've got low vitamin D and you put that in, same response. People aggravate, low anything. Um, it's that we, if that's your pattern, okay, we learned something here. You do need this addressed, but maybe not right now, or maybe in a very gentle way right now. And we need to fix the motor that we're trying to push harder that's not working. So then that goes to somewhere along the trail of trying to get your cell and your mitochondria cleaned up and working again. There's either impediments, which we know a lot more now about, like mitochondria get blocked for lots of reasons that have to do with those triggers, especially toxins and chronic infection things. So we probably need to um, either work on removing the blocks or supporting the system that's trying to repair things very gently and make you strong enough then to start to treat some of these triggers. And it's, personally, it, I've been working with people like this for 3 decades, and you can see the frustration if they don't verbalize it. You see it in their eyes, because it's like they just want to feel better, and you just want to be on the other side of this. And one of the things, and this also goes, I do a lot of, teaching and mentoring with newer doctors, and it's always human nature to want things to go faster than sometimes they really can. Like you're almost breaking the laws of physics to go as fast as you want to, because you want your patient to get better faster. They want to get better faster, and it's not that you have to suffer. It's not that you have to stew in chronic illness. But sometimes if you truly have a derailment in your cell danger response and we pushed on the gas too hard, we're going to have to slow down. We're going to have to do very um, supportive things, and essentially fix the motor so it'll handle putting energy through it, right?
Very
um,
interesting.
yeah, and that I think with truly long-term chronic illness folks, those are the clinical things where it takes a lot of refocusing and motivation, and also what I always tell people, there's a difference between a doctor telling you you're just sick and you're going to be sick. Like, that's not what we're doing. What we're saying is we push too hard and we can't make your body respond faster till we fix these things. So let's keep working on it, and doing it long enough. What I know is there also hits a point where you stop aggravating, and then your body's ready for
Hmm,
bigger support. And then you go from baby steps to regular steps to big steps.
interesting.
So it's not all darkness and gloom, but if that's happened to you, that's very normal in chronic illness.
I think that is just gold what you just shared there. I mean, I hope everybody replays that segment because it's such a misconception, you know, of, oh, just give these folks antioxidants or just give them B vitamins or, you
Yeah.
know, and to hear that from you and why that was really helpful. It's almost to me like it seems like there's a process of support that one needs, and then also more kind of taking things out versus putting stuff in.
Yeah. Yeah.
Like
Yeah.
support in your mind. I mean, I know that can mean a lot of things to different people, but like in these patients, what are some examples of support and then also just supportive early therapies?
Hmm. You know, um, we could take a couple of real time examples. One that just sort of popped into my head because I've seen this before, and this is this is even more basic than any other thing we've mentioned, but um, the your cells, all of them we all know we need minerals and we need trace minerals and all these things, right? And a lot of times we get dysfunction because the mitochondria are very sensitive to things like calcium and magnesium and different trace minerals and stuff. And even at that level, which is so core and basic to human cell biology, I've seen people aggravate because they started taking, minerals, and it seemed like they did the opposite of what those minerals were supposed to do.
Mhm.
And that's actually more common than one might think. Well, if we take a step even further back to, okay, we use the broken motor idea. What part of the motor is broken when we have this ubiquitous, group of metal minerals that should be going in the cell? Our cells use very elaborate transporting systems to get minerals in and out, and they're very sensitive to having the right amounts on each side of the in and out of the cell, in out of the mitochondria, etc. And certainly that can be bothered by toxic things and all manner of other stuff. But one of the things that gets depleted in chronic illness that people need for this transport is taurine. And taurine is an amino structure. It's not really a structural amino acid, but it fits. It's in the family because it looks like an amino acid. And I've had people literally where they were getting the opposite of whatever the mineral was supposed to do, and we stopped the minerals, got them to do some taurine to kind of build their levels up. Minerals go back in, and voila, they're like that's not their problem anymore. And I started with that because that's almost so basic that it's easy to overlook, but like that happens with people. Um, Sometimes if, let's say, we went to the other end of the spectrum on, a trigger that, let's say it's a chronic infection, like Epstein-Barr is the one everyone's heard of. There's lots of relatives of that and all. But you tried to treat it, and I've had this where, they came in and the lab says, oh, that's active, and you treat it, and they come in for a second opinion because all they did is get sick, during the treatment. Well, some of that is your immune system got stirred up, of course. Well, we don't want to leave your immune system with no help with something like that. But obviously, whatever treatment you did was too much. Now, it won't be too much in a few months, maybe, but right now it's too much. So, what I'll usually say is, why don't we do some things that we know would be supportive to your immune system maintaining balance? Okay. Because usually, if we have a response to trying to kill a bug, let's say, to use really simple terms, the immune system was not well coordinated enough to deal with the killing, and you only get sicker. Um, there are a lot of things that are immunomodulatory, and really, rather than jacking your immune system up, what you want is modulation because it's made to go in up and down cycles. So that, and this could be any number of things, but there are certain groups of, say, mushrooms that are very good at being immunomodulatory. They're not actually stimulating, they're more modulatory. There are certain botanical medicines that are really supportive of that, or combinations thereof. So sometimes it's like, yes, let's keep some pressure on this immune infectious problem, but let's start, you know, at the ground floor, support everything, and then maybe in a month or two you'll be ready to do a little bit more specific. Let's push back on that agent or something like that. Um, and I think, those are just two examples that are super common. The other one that happens to probably more people is, we mentioned thyroid. You get low thyroid function when you're chronically ill. It's just your body's fought and it can't fight anymore. If you give somebody thyroid and they're really depleted and the cell danger response is not feeding back correctly, thyroid's biggest impact is on your mitochondria. And if they're all sitting there confused about, they're still in the inflammatory phase, they can't get out of it, you just are making them work harder,
Mhm.
and they're sick, you know. And so they just make you feel like speedy and sick at the same time.
Mhm.
So in that case, it's more like, well, that's a little too stimulating. Let's do just some basic supportive things to help, kind of analogous to immune balance, but only for endocrine stuff. And then when the system cleans up a bit, we can revisit how much of that you need. Yeah. So those are those are real world conundrums. They happen all the time if you're chronically ill. And, from the practitioner side, it's like that's a sign. I know, I don't know which part, but I know that the cell danger response is stuck somewhere because your body's saying, we need this, can't handle it.
Yeah. Yeah. A couple more questions, and this I want to give you a chance to kind of help us understand some of the things you're focusing on these days. But there's my early exposure to this. There was a lot of this emphasis on, well, these let's repair the mitochondria. Like that's kind of the first step here is get the mitochondria healthy by lipid therapy and other things like that. And then I started hearing some pushback about doing that too early. I was wondering if you could comment on that first of all. Then I have another quick question.
Yeah. Yeah. That's another on my list of examples of doing things out of order. And it's not something like that's sort of a pejorative statement, but it's like you don't know what order is right until you try things. So sometimes you try and it's well meaning. Lipid therapies are profoundly beneficial on one hand, just like all the other things that we might do. And the idea, I mean, to simplify it, is that both the cell membrane and the mitochondrial membrane, when we're sick, they get full of essentially, junky lipid molecules and inflammatory things we don't want. So if we put some phospholipids in, which is a big part of those membranes, they'll go in and take, because your body knows what's good, it'll take the place and clean it up, right? And I've seen this, especially, I use a lot of lipid therapies, but I have learned that there's a good time for them, especially when you do them, say, intravenously, where, you're having a much faster
Mm.
effect than the person taking it orally. Although I've seen orally go wrong as well. um, and you have somebody where it's like, yes, they're chronically ill. Obviously, they're very inflamed. Lipid therapy should just, boom, this would be great. And then um, they really flare up. Well, there's a couple of uh, now that we know a little bit more about what's going on. There's a couple of reasons for that. One is, especially if you do intravenous lipid therapy, you can go in and yes, the new lipids go into the membranes, great. But what leaves the membranes? All of these oxidized partial phospholipids and old, kind of old dirty cell material, everything. It has to go somewhere. And these are, on the scale of things around your cells, these are big molecules. So then suddenly you have a bloodstream full of this stuff and your immune system sees it and doesn't know, what did we just do? People have had um, you can get fevers from it and all sorts of immune reactions. You can just be achy and you've just toxified yourself. You took the toxin from one compartment, moved them to another one, and your body wasn't ready for it.
Yeah.
um, so from a and I've used this analogy teaching, and it seems to stick better than what I just said, which is more mechanistic. It's like if you take and you're rehabbing a house, um, and the siding is bad, and you paint the siding. The rotten siding is just going to get more rotten on the
Mm.
inside. It's like lipid therapy kind of seals up all the membranes, which is great. But if you have a lot of toxic junk and you have a lot of, literally the cell danger response is just going looping, back to the inflammatory phase because the triggers never leave. What you're doing sort of is hemming in a lot of those, triggering
That
substances.
makes
So
sense.
it's a wonderful therapy. I tend to be a little more cautious on the front end till I know, oh, this person reacts actually pretty good to treatments. This person, everything flares them up. That's not the person that needs a lot of lipids, right?
Makes sense.
Um, yeah, so that's and it follows the pattern of thyroid at the wrong time or anti-infectives at whatever. It's kind of the same problem.
Interesting. Yeah. And so as we've been talking, I keep um, hearing the kind of flashbacks of things colleagues have said to me over the years, and I've always sort of like, yeah, that's not for me. I'm not that provider, but the more and more I get into this profession, now I'm almost,
Yeah.
getting close to 20 years in, the more what they were saying is really, starting to be more and more something I would adopt. And these are, kind of hearing you talk, I just think about these drainage therapies and various other modalities that a lot of chronic illness patients have or providers talk about in these early stages of these
Yeah.
sort of gentle medicinal therapies that kind of help the body drain themselves of these toxic materials and support the organs of elimination, um, without really pushing or hammering on the body. And then
Right.
also, I want to hear your thoughts about those, and then also things like bioenergetic treatments, biomats, and those types of things. Because I think people, after hearing this, are kind of probably going to be like, "Well, then what do I do?" And you've outlined a few
Yeah.
really good things, and I mean a lot of good things. But this is just another area that I want to just get your thoughts on.
Yeah, I think I'll try and go in the order you brought things up, but I think what I was trying to describe earlier, and I started with minerals and taurine because it's such a linear, microscopic example. But whenever I have somebody and they need XYZ, but they just react to the normal treatment, intensity, let's say, there's always things you can do to kind of dial it back. So you're still helping, but you're not pushing as hard on the system that just it doesn't need to be pushed on right now. So there's a few things. So one, which is a bit more of a project, is if the triggers are mitigatable and you could, you know, put something I do a lot is that people do most of their breathing repetitively in their bedroom where they sleep, and then in their office. So if I'm going to have somebody, invest in a air filtration system, I at least have those two rooms covered. Where you work and where you sleep. So just removing, like, take a few bricks off the pile. That's sort of the first thing. The next thing really is, even before you go to intervening, understanding that your body has, although they get overwhelmed, your body has natural ways where bad things come in and they can leave, whether it's breathing it out, sweating it out, going out through the liver and the GI tract, and the kidneys, all those things. So then you can say, all right, before maybe I do some things to help, have I, and you see this a lot with people, especially the reactive folks, have I just been sick so long that my liver and my kidneys really have a challenge trying to get rid of stuff, or my skin, or et cetera. So what can we do to help that? Now, some of those things wind up being, more, you could call the, physical interventions, physical medicine interventions. But you can start with real mild things. So obviously hydrating and having enough fiber in your diet so that the toxins don't recirculate from, your liver dumping them and things. So those are good things. But then also, like, it, and interestingly, and I think maybe I think of it more now because I understand the mechanics more. I've always used, like, red near infrared light has been used in physical therapy forever, as like, in different lights. But now we know a lot more about what that's doing, and you do have to be careful because people have, you know, they go essentially, near infrared penetrates a lot deeper than we thought it used to. People using near infrared mats, and we did this a lot during the earlier versions of COVID, where people had a lot of pneumonitis and things. They even wound up publishing some human interventions doing that with near infrared. We'd do it right over the chest and things to help clear up. A really old idea, but it turned out it worked. And because it was COVID, they did a research and figured out it was good. But something I've seen is, you take someone's chronically ill and whether it's more of a like a near infrared where you're doing topical application. And a lot of people have done this maybe for a sore wrist or elbow or something, but you actually can do it for your liver and other organs. Or if you go to far infrared to do like a sauna, I always start people with just a few minutes because, again, it's great, gets the mitochondria woken up and helps the processes to remove. But if there's an avalanche waiting to be removed, we don't want to be, you don't want to start at 30 or 45 minutes of treatment and then just feel really horrible.
Right.
So I think these physical things, you could do it with hot and cold and stuff, but like near infrared, start with a few minutes and it just helps to start get the ball rolling, the things like that. And then some people can ramp up real fast. So I've had some very toxic patients who literally had exposures to mercury and stuff where we had to go minute by minute. It was just very slow going. So stuff like that. And you mentioned biotherapeutics, of which there's many. uh, those are very, very well developed, more from Europe and Asia, where I've been to those places and seen people who do those things, and so we sort of have them here grafted over from other countries. The idea behind them is, if you look at most of them, whatever modality is used, it's a lot of times it's like really low dose plant medicines or other things put together. You'll almost always see, like, if they look at the targets, it's like a lot of organs. So it's not, we're not just hammering your liver. We're going to have all the immune organs sort of perk up. We're going to have all the eliminatory organs be supported. And sometimes with people, those can be very profound, because they start the ball rolling, but they don't blow them out of the water.
Yeah.
Same as physical medicines in my experience. And you can do the same thing with lymphatic massage and other things that can be helpful. You just have to start small, and if your tolerance is 10 times small, great. Your neighbor might be small. That's it. That's all they can do.
Yeah.
So
Great.
yeah.
Yeah, so that was really helpful. And I think it gives people like a foundation of things to bring up with their practitioners as well, and to not just go into this full guns a blazing and, you know, sort of
Right.
to really see the long game in this and what's required. So I really appreciate you being here. This was a really good and deep intro to cell danger response. And I'd just like to wrap up with just some closing words and also just to hear some things that you're up to, and share with the audience.
All right. Do
Yeah.
you want me to start? Okay. Okay. Um, well, I always stay busy, so I have plenty going on. I'm doing a lot of practitioner education these days. We do a live conference twice a year. We have an integrative cardiology one coming up, in Scottsdale, and I do a monthly practitioner CME that we now have credit through the AMA for. So that took
Mm.
years, but we got there.
Congratulations.
Yeah, yeah, finally made it. So those things keep me quite busy. I still have a practice that is half cancer patients, mostly children, sadly, and half very chronically ill people, like we're talking about here today. And they keep me learning because nobody's an easy answer in that group. Um, the other thing I think, it's interesting. I was sort of thinking about it as we talked today. I've been involved in lots of research, but I'm involved in some ongoing research, and we're it's always a long lead time to get things reviewed and published and things. But uh, I can't say a ton about like all the mechanisms, but one of the things that is sort of a modern scourge are microplastics, and I've been involved in some human research with looking at lowering microplastic levels in people and mechanisms to do that and all. And one of the interesting things is sort of a happy sort of side benefit of some of the procedures to lower microplastics is people who are super reactive and chronically ill, the less of this, heavy duty, large molecule garbage, less of it in their body, the less reactive they are and the easier their chronic illnesses are to treat. And in some cases, and of course, other bad things leave when you take microplastics out. It could be mold toxins or all kinds of stuff. So that's been really exciting to see. And as soon as I know there's 3 different papers we're working on, as soon as it gets through peer review, I'm going to tell everybody so I can do
Excellent.
that. But
Look forward to that.
um, yeah. So that's me.
Well, excellent. Well, thank you so much. And like over your shoulders, I want people to know that the books that you have, published, you can see those, and I'll put links to those in the show notes. Some really great books on cancer therapies and integrative treatments for cancer, and just the process of the kind of mind body kind of connection to being a cancer patient or a cancer family. And I know you've really inspired a lot of people and practitioners. If people haven't heard this already, Dr. A is sort of our modern kind of main educator for the generation of naturopathic and functional medicine practitioners that are out there. And we've really are grateful for you, and hope you know that. I hope you feel that, because it's a lot what you do, and I know you're there for a lot of people. So thank you for everything, and we carry forth your mission, and trying to help a lot of people with the information you share.
Thank you so much. I do feel it.
Good,
Yeah.
good.
Thank,
All right. Well, thank you for being here, and I look forward to continuing to keep in touch with you.
thank you so much. Thanks for having me.
Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from it. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.